Okay, we're back. We have Nathan Carlson and Chris Johnson. Thank you all both for coming on. Chris, you were on a while back on E3, but would you all both mind giving a little intro, where you all located, what you all's current kind of positions are, and then we can go into the course that you all are about to host. Let's start. Nathan, you can go first if you want.
Cool. Yeah. Thanks for letting me come on and chat, and Chris too, I guess. So I'm a PT and a coach based out of Kansas City, Missouri, right in the middle of the country. And my clinical work is focused on runners and triathletes to an extent because of the running component. So I have a business that's about half rehab, where we're dealing with injuries, about half where we're dealing more with performance, whether that's we're worried about getting hurt or have some kind of performance goal that we're trying to go after. So that's what my practice is built around. And I have a particular interest in bone stress injury management, and that's come up over the last 5 or 6 years. And that's the thing that I teach in the course that you'd mentioned, that Chris and I host. And so I spend a lot of time thinking about bones, people worried about bones that are going to break, or trying to help them get back after they've sustained some kind of injury. So, yeah.
Perfect. How about yourself, Chris?
Yeah, well, thanks so much for having us on. When we did the podcast in the past, I listened to it, and I don't usually listen to podcasts after I go on, and I thought that was a really great conversation, and I hope it helps a lot of your listeners. And I just want to compliment you, brother. You have a really great presence about yourself. I didn't know when they brought you on to start helping out with the podcast, but I was tuning into Alex Natera's podcast that you and Sam did, and just thought that you guys hit that out of the park. I am a licensed PT like Nathan. We work in similar capacities where we're sort of working with athletes across the injury to performance spectrum. So I do a lot of consultation as far as physical therapy goes, and then I have a roster of athletes who I help. And then Nathan and I try to synthesize a lot of the research on lower limb tendinopathy and bone stress injuries, and try to just give clinicians refined understanding and just actionable items, in a framework. So when they go into the clinic and they have a runner or triathlete land on their schedule, that they know what to do. So, and I'm right up the street from you, which I just learned 5 minutes ago. So, yeah.
That's right. Well, thank you for saying those kind words, Chris. I appreciate it. The course that y'all are about to host in, I believe, Nashville, is that correct?
Correct.
Tennessee.
Yep.
Yeah. So bones, tendons, weights, and whistles, that's the topic we're going to chat about today. But I would love for y'all to promote the course itself, what it consists of, what the goals are, and then really the priority for today is to dive into both tendinopathies and bone stress injuries. But either Nathan or Chris, if y'all want to discuss the course.
Sure. Chris and I put this together. It was probably towards the end of 2019, just with the idea of kind of what he alluded to when he was doing his little introduction of, runners tend to get hit with bone stress injuries and tendinopathies, and trying to help clinicians so they know they have a good idea of what to do when those two diagnoses kind of walk into the door, whether they've been diagnosed yet or they're at some point along the return to sport spectrum. And putting that together started 3 or 4 years ago, and then we've taught virtually, we've taught in person, through the pandemic, and then and feel like as the course has evolved, as that stuff always does, it's hopefully gotten even more simpler and actionable. But to be something that clinicians, when they have a runner walk in, they feel confident that they know how to handle their situation and try to figure out how to help them out.
So the plan for today is we're going to go through both of these tendinopathy and BSI components. What does it look like for an initial exam, and all the way through treatment and common mistakes. And we'll kind of go back and forth between Chris and Nathan. So let's start with an initial examination. A patient's coming in and they're presenting with potentially a tendinopathy. We'll start with Chris. Someone's coming in, what are the potential differentials that are going through your head when a runner's coming in, they have specific complaints, what things outside of a tendinopathy or including a tendinopathy are you thinking through? And then what key questions are you asking to guide your thought process?
Yeah, I suppose I can step in here. As much as we talk about the science of bone stress injuries and lower limb tendinopathy, um, when you first connect with any patient, we'll stick with the theme of runners and triathletes, I think it's really important to understand that people are in a one down position, meaning that they have a problem, they're not thrilled about it. It's probably disrupting their schedule and just their mental health and well-being. So when you first connect with people, you have to be very cautious about trying to swoop in and go into doctor mode and say, okay, here's your problem. Here's what you're doing wrong. This is what we're going to do to fix you. You really have to equilibrate that situation where you get on the same page, where you're more equals and you're troubleshooting with that athlete. So you never want to give them the sense that like you're a fixer or you're coming to their rescue, because people, they have a much better sense of what their next move is, generally speaking. And so you want to just connect with them and start to form an alliance and really trust. And this is something that really gets glossed over, with a lot of the content that I think anyone puts out online. So our goal is to really, form a good working partnership with that athlete, because as they start to trust us, they're going to start disclosing more meaningful information that's going to, dramatically impact our decision making and how we troubleshoot with them. So just as much as we'll get into questions, and I don't want to steal Nathan's thunder here about specific questions you'd have about bone stress injuries, as well as lower limb tendinopathy, you have to first get on the same page with that athlete. And I think that I used to make the mistake of trying to swoop in and, solve a person's problem. And I realized that does not work.
So to that point, what do you think is our initial role if they're coming in and how are you guiding the setting expectations for what this interaction of care looks like for, let's say you do find a tendinopathy or just in general?
Do you want to chime in, Nathan?
Sure. So, I think anytime a runner comes in with pain or some type of a loss of function, you can kind of go back, I think, to PT School 101, the stuff that you learn about that maybe you gloss over once you get into clinical practice. So simple stuff like, where is the pain located? Is it located over a tendon that has to work a lot when you run? So when you're thinking about runners, you're going to see a lot of runners that get patella tendinopathy, Achilles tendinopathy, proximal hamstring tendinopathy, glute med tendinopathy. There's really like 5 or 6 locations where if someone comes in and they say, I have pain here when I run, you're probably going to start thinking that this is a tendon. This is more of a tendon. And this is really important because the management of a tendinopathy versus something else can be drastically different, especially when we get into bone stress injuries. I think looking at behavior is very important. So, is this something that warms up? Is this something that's variable in its presentation? Often that tends to be more along the lines of a tendinopathy if symptoms are consistently getting worse. And so I'll often, have the idea of like, almost like a cliff where, my pain is here and it's getting worse, and my function is getting less and less and less. That's often much more indicative of what a bone stress injury feels like, or what patients will start to talk about. Tendons might be more up and down. There's times when it feels okay, times when it might not feel as great. And being able to go into some specific questions on that can be really helpful, especially if this is someone that their initial kind of entry to the healthcare system is seeing a rehab provider versus a physician or somebody else.
And I think what Nathan, is really getting at here is we're trying to stage and type the presentation. Is this someone coming in who is able to currently tolerate some form of running, or are they at a point where they're getting pushed back with just routine activities of daily living? So obviously, if someone is not able to get through the day and maybe they're not even tolerant of weight bearing without pain, and you're suspicious of a bone stress injury, well, that's obviously going to dictate your decision making. So this is something that when you have oncologists or docs working with people who have cancer, what do? They stage it and they type it right off the bat, because that's going to influence their treatment plan. And I think that we should be thinking of anyone who comes in with a lower limb tendinopathy or bone stress injury in a somewhat similar manner.
Nathan, you have anything to add to that?
Yeah, and when Chris talks about that, so if someone comes in and they're having pain with running, and that's bleeding over into their day-to-day activities, and it's not getting better. There are times when that happens with tendons, but they will almost always be pain that's located to a tendon. They'll be red, swollen. When you go through a clinical examination, again, going back to kind of what you learned in PT school, if you load the tendon, it's bothersome. If you stretch the tendon, it's bothersome. That is what that tends to present like with a tendinopathy. But the second someone is like, this has been really bothering me for a period of time, and that pain is not over one of those common locations, in my experience, it's almost bone stress injury comes to the top of the list, and we need to figure out how to rule that in or rule that out. And often that's when imaging comes in. I think as with clinicians, as you gain more experience or you see more reps with this, it becomes much easier to do that, to say, if someone's coming in limping into the clinic and they're saying my hip hurts, you probably don't need to see me. Rehab, PT, chiro, whoever's seeing that athletic training room, this is probably not something for us to manage right now. We need to get you with a physician. We need to get some imaging. If someone can order imaging to rule this in or rule that out, because the implications are very different. Whereas, when Chris talks about tendinopathy, there's a chance you're still running. There's a chance you're still completing everything on your training schedule, just because of the nature of how muscles and tendons behave versus how bones tend to behave.
And I think with any runner who comes into the clinic, you first, and Nathan always makes this point when we teach, is this person a candidate for physical therapy in the first place? So if they have all the signs and symptoms of a bone stress injury in a high risk site, you're saying, look, at some point we're going to connect and we're going to formulate, a treatment plan. But right now, we need to make sure we know what we're dealing with, because if you have a proximal femur bone stress injury and we get this wrong, the implications could be grave. Now, you're not explaining it to the patient in exactly those terms, but you need to say, like, we work in direct access. Pretty much all of our patients, come to us through direct access. So, we're in a position where we have to triage. We both had 2 patients recently, runners who had very atypical presentations and slipping rib syndrome. Do you even know of this? So Nathan and I didn't really know about it. I'd heard it in passing, and we had 2 runners and they fit the script. And that's someone who you probably want to get in, and you can initiate a plan, but you may want to get them in to see a PM&R doc or someone who specializes in diagnostic ultrasound to see what's going on, because again, maybe physical therapy in and of itself isn't going to get them out of trouble.
So let's say you're suspecting a bone stress injury. What sites are considered high risk? And then what sites are considered low risk? If it is a lower risk site, is there still a pretty quick referral to imaging, or does that kind of delay, or are you a little bit hesitant to start that process just because there's less risk involved?
Yeah, and this is always a dance that you kind of have to do with the patient, because the management of these can be very different. So every bone in your body, that we grade these as low risk or high risk. Sometimes you'll see a moderate risk category, but for the most part, low risk and high risk sites. So when we're talking about that, The thought is we're going to do that based off of the chances that this is going to heal on its own, so we can manage it conservatively. That has a lot to do with the specific biomechanics and the loads that are going through a specific location. So bones like to deal with compression. They like to be squeezed together. If you have a location that is primarily tensile in nature, where it has to deal with more tensile or stretching type forces, those are harder to heal in and of itself. Some locations have better blood flow than others. And so if you have an injury and you don't have good nutrients or good resources going to the area, it might not be able to heal well on its own. And there's locations that tend to be at a higher risk for avascular necrosis, or when the bone actually dies. And when that happens, that's probably the worst outcome that we can have. So that's surgery. That's you're not running. If it's in the hip, that's a total hip. Then there's different ways to manage that. So all the sites have different locations. In general, the big ones that we tend to see with runners that come into the clinic are the proximal femur. So that's the femoral neck specifically. That's the navicular, so on the inside of the foot, and then the fifth metatarsal. Those are the three big ones that you'll see in runners. There's other ones that you can see in dancers and in other types of athletics, but those are the big ones that we'll see. Rarely you'll also see the anterior tibial cortex. So that's the front part of the tibia. And again, because of the unique nature of those specific areas, often those need a referral to a surgeon or to figure out what else might be going on. And so if those are the case, if someone walks in and you're having pain in any of those locations and it kind of fits the same classification where a gradual onset of symptoms that's worse with weight bearing that's not getting better, we often have to go non-weight bearing. So, even if someone comes and sees me and we can't get them in for imaging for a couple of days, I'll tell them I need you to pick up a set of crutches and you need to stay on them until you get the image. And then if it comes back clean, we're okay. We can progress back, but we do, that tends to be helpful if we can take some load off the area. Very different than how we manage a low risk site. So there's a really good paper by Stuart Warden, Rich Woolley, and Brent Edwards that looked at the management of these. And their kind of argument, and this is what you'll see in the clinic too, is if someone's having symptoms in a low risk site, it's really based off of what their tolerance is as far as how you're going to manage it. So say Chris, you come and see me, and we really are confident that this is a tibial bone stress injury and it's a lower graded one. And you're like, hey, I can walk around, I can go to class, I'm in college, I can do that, but I can't run. I want to keep you doing as much as possible. So everything that you can do that's not symptomatic, I want to keep in your repertoire, because if we start to pull people away, the recovery or the timeline becomes so much longer. So that's one of my priorities with low risk sites is I want you doing as much as possible that isn't bringing on symptoms. Now, if you come in and you're like, it hurts walking around, I can't do anything, even in those low risk sites, sometimes we might have to get you a cam boot, get you on crutches for a period of time. But the time period for that is much shorter than those high risk sites. And again, with those high risk sites, what we're really trying to do is minimize really adverse outcomes like surgery or avascular necrosis. And so understanding where those locations are is really important. A paper to read up on that is Management and Prevention of Low Bone Stress Injuries in Long Distance Runners. This came out a few years ago. They have a really nice table that kind of breaks all those down. But that's what you're trying to figure out when someone comes in. Once you've kind of gotten to the point of saying, I think this might be a bone that's involved, understanding what's the likelihood of this being a high risk or low risk site, and then often referring for imaging at that point, whether that's a provider getting in with a sports med doc, whatever kind of resources someone might have.
And the starting the process of returning back to running or finding what their threshold of tolerance is, bone stress injuries compared to tendinopathies, how are you framing tolerance and symptom thresholds from a BSI perspective versus a tendinopathy perspective in regards to, can they train certain activities with symptoms in both, or how do you differentiate that?
Sure. Chris, you want to do tendons? And then I'll come back and talk about bones.
Yeah. There are definitely different considerations here, and with lower limb tendinopathy, the Achilles is tough to train through. I had a reactive Achilles tendinopathy, and I really had to shut myself down because, as the saying goes, there's no place for the calf and the Achilles tendon to hide when it comes to distance running, because 50% of the energy comes from those tissues. Now, you can absolutely keep training in the context of most lower limb tendinopathies. So, when we teach this course, we sort of, give people the impression like you can be a little bit more cavalier with tendons, because if you get it wrong, you may sensitize the person, flare them up a little bit, but their symptoms will probably calm down within 48 to 72 hours, even if you make a really hasty, training error. So, I've dealt with the patellar tendinopathy we've talked about on our podcast, and I never stopped training through it, and that was, one of them took about 10 to 12 months and the other one took 16 months. So I had to be a little bit more conservative with, running fast, especially if I was going downhill. People who have proximal hamstring tendinopathy tend to be fine. If they're on level ground to gently rolling terrain, it's not until they get into, say a hilly trail run where there's more incline or ascent where they start to get pushback. But when you are crafting a return to running program, what do we know about tendons? There's this warm-up phenomenon. So you want to afford the tendon time to warm up. So, if you look at any of the programs that we write for people when they're starting to plug back into training, we always encourage them to just walk for 10 minutes. People always say, "Hey, what do you do for, your warm-up before you run?" I'm like, "You ready for this?" I have them walk for 10 minutes. Let the tendon warm up, and then start with just a lower intensity run, and then you can bleed into the crux of the workout. So you're really modifying, you're having to keep tabs on incline, decline, pace, terrain, factors like that. If someone has an Achilles tendinopathy, you're probably not going to want them on the treadmill, because Rich Willie and his team have shown that starts to bias a load to the Achilles tendon. So it's just understanding how to dance, but you can be a little bit more cavalier with tendons. You can have people work through some pain, even if it's up to a 5 out of 10, so long as those symptoms, are returning to baseline within the ensuing 24 hours or by the following morning, which is very different from bone stress injuries, which Nathan will get into. Nathan, do you want to cover bone stress injuries in terms of like return to running?
Sure. Yeah. And I think that, we talked about communication a little bit already, but that becomes really important with this, because with either one of these diagnoses, this isn't going to be something that it's going to be immediately solved often. Sometimes that'll happen, but those are rare instances. Now, the management of bone stress injuries, it's pretty different than tendons. And so, we basically don't want any pain. So, 1 out of 10 is what they'll say in the literature, but I'll tell people, I don't want you feeling anything, especially as you return to run. Now, in my perspective, one of the things that I think we often don't do a good job of is preparing someone for running that hasn't ran in a while. So again, with bone stress injuries, that you're going to have a time period where your body is doing something different than what it's used to. So you're not getting as many steps in your day. You're not running, so you're not dealing with impact. Maybe you're not lifting. Maybe you're not weight bearing. And so I think that you have to respect that when you're looking at what all I want to accomplish before we can even start a return to run progression. In my perspective, we need to make sure you can walk for an hour. You can tolerate bilateral and unilateral plyometrics. We've probably done some lifting, squatting, deadlifting, all those kind of things. We've done a lot of single leg tasks. So I want all that to happen before we start a return to run progression. And all that serves as checks for progress along the way too. So if I can take you through all of those different things, higher loads, faster contractions, all those kind of things through the area where the bone stress injury was, and you don't have symptoms, that helps me know kind of where we're at in the rehab plan, because pain is our main thing that we're watching from an outcome perspective. And then it's the same thing once we start running. So when people start a return to run progression after they've had time off, whether they have a bone stress injury or they just haven't ran in a few years, maybe they've had a kid, maybe they're trying to get back in shape, whatever it is, when people start to run again, it almost always feels like garbage. And anybody that's had that experience knows this. You feel sluggish, you feel sloppy, you feel like you're really heavy. And so I'll talk people through that. It's very normal when you start this to feel off or to even have a little bit of discomfort, but you don't want the same symptoms that you were having before or symptoms in the location where the injury was. So again, this is why understanding the location is really, really important. And understand that you might feel tightness or fatigue or all those kind of things. So I don't want any of that during their return to run progression. We haven't touched on this as well at this point, but we also want to make sure that they know how to handle the progression into exercise, but also into nutrition. If you spend any time with runners, you'll understand that nutrition can play a huge role in why these things happen. And from my perspective, this is almost always a fueling issue before it's a training decision issue. So if you look in the literature on running related injuries, they'll talk about how training errors are the biggest cause. With bone stress injuries, I just assume that this is a fueling issue before we even talk about training. You can definitely progress too quickly, but we have to rule out that nutrition isn't a part of this before we can really talk about how we should be approaching running. And that's going to be getting them with a good dietitian, whether that's locally or somewhere else, someone that's very skilled in managing the endurance athlete. So we want all that to happen before we really start a return to run progression. And then we want that same, 0 out of 10 pain as they progress back into, running for longer durations, adding in back-to-back days, adding in some intensity at some point, and going back to that paper by Stu Warden and colleagues. That's kind of what they'll talk about as far as how to progress back into training, is to start with frequency first. So get them running on a more frequent basis, build their duration up, and then add in intensity, and just do that slowly over time. And Chris alluded to the recovery timelines for tendinopathy can be quite long. I think we should probably frame rehab for a bone stress injury much closer to how we look at ACL reconstructions from a timeline perspective, because you can normally run in between 2 to 4 months after diagnosis, depending on the site. But, for you to really be in a good position, we're probably looking more at the 9 to 12 month range, because normally we're talking about, time off of running. We're changing things from a nutritional standpoint. Maybe we have other referrals we have to work with. And when you stop running for a long time, your fitness comes down really quick. Chris had a really good post on this the other day on Instagram, just talking about how quickly you lose fitness or your cardiovascular fitness when you stop running. And so it's a slow, steady process. And for me, that we're looking at 9 to 12 months probably before we're really back to, okay, I can definitely compete at the level that I want to compete at.
And there's a phrase, Nathan has alluded to this article from Rich Willie, Brent Edwards, and Stu Warden. And it's really important to work this into your discussions when you help runners conceptualize what that return to running program looks like for a bone stress injury. And they use the term controlled bone loading sessions. So you don't want people to think, yeah, I'm going to plug back into training. No, you're trying to basically ensure the bone has a capacity to withstand the forces, and to really de-emphasize any kind of speed. Like, people who may traditionally, like I think of a pro triathlete who I consulted recently, and, I'm like, look, dude, I don't want you dropping below 8:30 pace. And that's even pushing it, so you just want to really make sure you get these people out of the gates, because if you get it wrong, you're going to just really prolong the recovery and risk re-injury.
And that's really challenging for rehab providers, depending on your specific clinical situation and what the environment is like around the athlete. So, sometimes insurance benefits run out and someone literally they can't stay any longer as a patient for whatever reason. And so that can mean that you might not be able to work with this person for the length that you would want to. And then also, most of the athletes that I work with will transition back to some coach that's not me, whether that's a private coach. Some of them will be self-coached, but definitely when working with like high school, college, and pros, there's going to be a coach that's going to be making some of those decisions, and they might not have the same approach to this that Chris or myself might think is appropriate. And so trying to empower the athlete to be able to navigate this stuff, especially if they're going back to an maybe a little bit of a dicey situation, can be really, really important. So, I had an athlete last year who got plugged back in and did really well for about 6 months, a college runner, and coach decided that they needed to do four workouts in the span of 10 days, and immediately went south really quick. And again, from my perspective, I think that was probably not the best training decision, but I'm not providing that person coaching services, and they're on a team somewhere, and so, talking with athletes about this, whether they're adults, whether they're high school, college kids, can be really important about expectations and what a sensible progression looks like, and helping them feel like they can make those decisions about, what do I do in the moment of a workout or a long run or a race when I feel off or something doesn't feel right. Because anybody that's played sports know there's an element of pushing through discomfort that comes with training and competition, but there's also a time where you want to listen to whatever that internal dialogue is. And so that can be a huge part of this as they start to navigate training and competition, in the long run.
So Nathan, you mentioned the likelihood of receiving imaging for bone stress injuries. For either imaging for BSIs or for tendinopathies, what is the evidence show of, do we need full healing for complete reintroduction to activities from a bone stress injury perspective and from a tendinopathy perspective? Let's start BSI first. Nathan, if you want to start.
Yeah, that's a great question. And I do think it can be challenging at times. So, for most running related injuries, I don't think imaging is often like the first thing that we need to do. But in the context of bone, it often is, partly because that's really our best way of diagnosing bone stress injuries is an MRI. Even X-rays, radiographs can pick up some in the low risk sites, but they're not 100%. So you really have to go straight to an MRI to confidently say yes or no on if that's the diagnosis that we're dealing with. And then beyond that, kind of going to, again, specific locations. So even specific locations within the same bone managed differently. So we're going to want an MRI for that. And lastly, grading. So lower graded MRIs, grade 1, grade 2 versus grade 3, grade 4. We think that the grade of bone stress injury tends to be pretty well correlated to the timeline for recovery. So all of that does help us from a clinical decision-making standpoint on how to progress through there. Now, as we see with a lot of tissues in the body right now, that has to match someone's clinical presentation. So they've done studies on basketball players and distance runners and ballerinas where they'll do MRIs on their lower legs in the middle of a competitive season, and they'll find imaging findings that are matching low-grade stress reactions. So you'll see this in the metatarsals of basketball players. You'll see this in the feet of dancers, and you'll see this in the shins of runners. And so that imaging, if it isn't matched with a relevant clinical exam or how someone is describing, how they're able to go through training, it always has to match. And I think that's really important when we look at healing. Now, pain is our best guide in rehab for making progress. There are some sites, specifically those higher risk sites, and I'll see this a lot with the navicular, where we want to see positive changes from a healing perspective, because that probably means we aren't as likely to need surgery. But if someone has maybe plateaued from a healing perspective and they're tolerant to single leg exercises, plyometrics, a run progression, all those kind of things, I don't think that it means we have to pull them out of training. And so the imaging can be really important. It can be very important with diagnosis. This is really challenging when we talk to clinicians from Canada, because it might not be as easy to get an MRI really quickly up there. But it can be a really important part of the diagnosis. But it's not always cut and dry really after we move beyond that. And so from my perspective, we're always matching imaging and whatever their clinical exam and their subjective reports are to really try to figure out if we're moving in the right direction or if we need to make a change.
Chris, what about from a tendinopathy perspective?
Yeah, for lower limb tendinopathy, very rarely do I have people go and get imaging for a couple reasons. And I want to circle back to something with bone stress injuries after this, but Sean Docking, who's part of the group out of La Trobe University in Australia, I believe he's still there. He had a great statement in one of his JOSPT articles saying, "A picture is worth 1,000 words, but only as an adjunct to the clinical picture." So with lower limb tendinopathy, again, MRs, the gold standard. Some people will do diagnostic ultrasound, but very rarely should you be shuttling people off for imaging. The one exception would be the proximal hamstring, just because there's a bunch of different sources of nociception in that region. So if things aren't presenting 100% consistent with a PHT, a proximal hamstring tendinopathy, and people aren't making headway with their rehab based on what you would expect, yeah, that would be a case where maybe you do get imaging. Now, the tricky thing with imaging with lower limb tendinopathy is you can have a radiologist read that is, what's tendinopathic tissue, that can get read as a partial tear. Now, that becomes a whole nother, you're opening Pandora's box, because if you don't take the time to collect a detailed history and someone doesn't report an acute tearing sensation or they don't experience that, that's just tendinopathic tissue. So now that does put someone at a much greater risk of developing an active tendinopathy. It's sort of, Greg Lehman will use the analogy of it's sort of like having kindling next to a fire. It's not going to take flame unless you put a match to it, but it does put you at risk. I think that was Sean McAleef's work. So, but yeah, I can't think of the last person that I had go and get imaging for a lower limb tendinopathy, because you can generally get these calmed down, and it's really with runners, energy storage and release that you have to keep tabs on. I wanted to make one point, which is really like, we do send people off for imaging with bone stress injuries, especially with high risk sites. But one of the things that you have to be really careful about is, with the pro triathlete who I mentioned earlier, he was dealing with a proximal femur bone stress injury, lesser trochanter, and he had follow-up imaging at 6 weeks from the initial diagnosis. And the doc said, "Look, great news. The stress fracture is healed." Now, what he interpreted that as is, I'm good to go. I'm ready to plug back into training the way I was. And even though that image is clean, that does not reflect the properties of that damn bone. And he could go on and just land himself right back to where he was. So with imaging, you have to be so careful, because there are implications, and oftentimes you pull that lever and send someone off for imaging. You don't know what's going to happen. So you need to really make sure you're in communication and that athlete's getting the same message from the radiologist, the treating orthopedist, as well as yourself, because if you start sending mixed messages, it's just going to create anxiety on the part of the athlete.
Yeah. So, there's a huge communication load on the clinician in these situations. And so I think that's often why, I think you can choose two paths with this. It's don't do that. Don't involve yourself for that, or don't take that level of care to the situation, or do that and know that it's going to be a lot more work. And the athlete might disagree with you on how you're going to manage that. And so, our role as rehab professionals is to educate them and talk about risks and all those kind of things. And then at the end of the day, the individual is going to choose what they want to do. You just want to make sure they can make an informed decision. I think this is really important as we talk to, getting back to competition, which is, it always is a little bit of a guess. Chris talked about the athlete that he's been working with, and MRIs are great, right? Because they can show healing, but the bone's really complex, and so there's the bone is healed, as in there's no fracture line present, but as we start to zoom in on kind of the nature of bone, there's a whole nother thing that goes into healing, whether we're looking at bone density, the microarchitecture of the bone specifically in that area. All that takes a much longer time period to heal than, again, a lot of people realize. If anybody sees stuff I put out on social media, I talk about a study by Kristen Pope a lot that looked at bone mineral density following a tibial bone stress injury. So a denser bone is less likely to break. So bone mineral density, which we get through a DEXA scan, is really, really important and is often something we might want to do once someone is diagnosed. And what they found was that the initial 12 weeks after the injury, the 30 subjects in the study had a decrease in their bone mineral density, which is pretty expected because they're doing less. And when you do less, your bones adapt to that. But over time, only 20 out of the 30 returned their full bone mineral density at the 12-month mark, so a year later. And so 10 of them didn't. And that plays a big role in, again, their risk for fracture or risk for another bone stress injury. And so talking them through how to approach this can be really important. One of the nice things about tendon rehab is it's generally painful, which doesn't sound like a good thing, but it can help you maybe realize where you're at from a progression standpoint. If you go non-weight bearing for a couple of weeks after a bone stress injury, your pain's almost always gone. And so you don't really have that to check in with yourself. And if you do, if pain ever comes back, it almost always means we've made a big miscalculation and we have to step way back. And so that's why I think one of the most challenging parts is any point along the way, kind of like Chris's patient athletes or a coach for an athlete or a parent for an athlete will go, okay, I'm good. And I'm going to plug back in now. And then we see this big spike. And so, I talk with every patient I work with this, where my goal is if we can get you to a year and we get back to whatever training was looking like before, I think we've really reduced your risk of having another one of these. And that can be really challenging because a lot of times people will, re-aggravate it or they'll get another one in a different location. And so having that communication along the way and having a good working relationship, Chris talked about this at the start, like that's the real big crux with this, especially because along the way, you might have to have conversations about some sensitive topics because things like reproductive health, the relationship with food, lots of other things can play a much bigger role than their training decisions when it comes to diagnosing and preventing these from happening as best as we can.
To that point, are there similar themes and reasons as to why some individuals get a BSI and some individuals get a tendinopathy? Or how different is the mechanism for some individuals chronically have tendinopathies and some people have these either one BSI or these recurrent BSIs? What are the similarities of why they occur? And then what are some distinct differences? Chris, if you want to start.
Yeah, I mean, I think that, Nathan mentioned that, let's just say the way you approach training, in terms of frequency, duration, intensity is really important. So obviously, runners, a lot of times will cling to high mileage, whether that's, from their coach's philosophy on training. But I think that training errors account for a lot of this. But with BSIs, yeah, I mean, the fueling, as Nathan mentioned, is really important. There's some interesting research. There's a paper about the jumper's paradox. So people who tend to be very good at using their tendons, surprise, surprise, get lower limb tendon issues. But I think with bone, as Nathan mentioned, it's much more of a complex beast. I don't know if that answers your question.
Yeah, I think we start with genetics, which unfortunately you don't get to choose. So bone mineral density is going to be the variable that you'll see. Bone mineral density and reproductive health. Those are really the two big things that people are going to talk about when they're looking at risk factors for a bone stress injury. So your bone mineral density is about 60 to 80% genetics. So some of it's modifiable, but a lot of it's not. So, do you have family members that have a history of osteoporosis, osteopenia, other kind of bone disorders? That can play a big role in this. But I think the big things that you'll see is, when we look at studies of high school runners, studies of collegiate runners, if they're at a much higher risk of having low bone mineral density in general, and that is going to put them at a greater risk of getting one of these. When we look at reproductive health, I talk about this like a switch. So our body is prioritized to stay alive. It doesn't really care so much about your training. It's just trying to not die. And what happens is if we start to maybe underfuel, which is one of the big things you're going to see with this diagnosis, is there's going to be a higher risk of low energy availability, or RED-S, those two different things. Whether that's somebody that's consciously doing that or unconsciously, whether that's someone that has an eating disorder or disordered eating, or they're just unconsciously underfueling, that's going to play a big role in this. And when that happens, when we have a mismatch between the food that we're taking in and the energy expenditure that we're putting out, that's when our body starts to shift its priorities, and it does that at the expense of reproductive health. So in females, you're going to see menstrual dysfunction. And in males, you're going to see a decrease in libido. So there's two different pathways that work towards this. But there's a really nice paper that got put up by lots of different physicians that are kind of at the forefront of this, called the Male Athlete Triad Coalition, or the Athlete Triad Coalition. They had a 2-part paper that came out last year with lots of good questions to ask. But those things are going to put you at a much higher risk if you have genetics that maybe aren't in your favor. If you are under fueling, those are going to be the biggest risk factors for why you might develop a bone stress injury. The other risk factors are I think are a lot harder to change. So you'll hear mileage get quoted, but the mileage that they talk about that really increases your risk for a bone stress injury is 20 miles a week. And if you're a runner that's training for a 10K, you're going to be running more than that. Every high school runner that's running for their school, college runner, they're going to be running more than 20 miles a week. Adults training for halves and full marathons, Ironmans, all that kind of stuff, they're going to run more than that. And so I think those training decisions matter. But in the context of bone stress injuries, the things that you're really going to want to try to address before they become a problem, or assess if you do develop one, are the athlete's relationship with food and their reproductive health and bone health based off of those things.
From a resistance training perspective, does anything change in regards to rehabbing tendinopathies and BSIs? Are you looking at the ways you're programming and implementing strength training and resistance training? We'll start, Nathan, if you want to start with that one.
Sure. I think there are some pretty good implications for bone. So going back to, we'll talk about Stuart Worden and Brent Edwards and Rich Willey again. There's a really nice paper on kind of exercise prescription for bone stress injuries. There's lots of literature on this kind of stuff. And to me, it's matching what we see with kind of the practical nature of life. And so before someone runs, I want to make sure they can load the area where the fracture happened on one leg, and then with weight and with speed. So if someone has a stress fracture in their foot, I want to make sure they can march. I want to make sure they can do a step up. I want to make sure they can do a step down. Eventually, I want to make sure they can do a calf raise with a barbell with extra weight on it. I want to make sure they can do plyometrics. So progressive overload to where the injury happened, I think, is really important. And again, something that sometimes we miscalculate in the rehab process. We tend to keep people pretty low level. The forces that are going through your skeleton even when you're a distance runner are quite a lot. And so I think that our exercise prescription needs to match that. So I want to make sure we've loaded the fracture site with progressive weight and progressive speed, and that we don't get carried away on volume. So you don't need a million exercises. Often I'll use an example of someone I saw yesterday. So femoral shaft fracture, 16 weeks out post-diagnosis, back to running, can run 45 minutes. I think we want to have them lifting on their non-running days. So we want to keep that rhythm of run one day, lift one day, run one day, off one day. So I'm going to have them lift 2 days a week. I want to have them do something that loads their femur, so a split squat with weight, because that should help drive the adaptions that we want to that area. I want to make sure that they can tolerate a farmer's carry. So they have extra weight on one leg, moving in the manner that they have to work with running. And then I want to make sure that they can tolerate single leg hopping. So if I boil down a strength training regimen to just those three things, that's what I want to do. I think we can add more exercises. We can do more. We can always add more to someone's schedule. But if we can do a big movement with progressive weight, a single leg movement that loads where the fracture happened, and then something that's powerful in nature. So that could be a plyometric, that could be a med ball throw, that could be just a regular exercise, just at an increased speed. If we can get those three things, then I think we're doing a lot of good. And then it's about matching what they have access to, what their time constraints are. And truthfully, over time, as running probably takes up more of their time as they're running more often, we simplify that as much as we need to. But the idea is that we're trying to do that to optimize bone strength. And we can do that if we load the area, load it the way that it has to work when you run, load it with progressive overload, and then we don't do a ton of volume because you don't need a lot.
Chris, what, if anything, changes from a tendinopathy perspective?
Yeah, so I think the main thing to understand, something that we drive home in the Bones, Tendons, Weights, and Whistles course is, as much as we try and parse this stuff out, you're dealing with the muscle, tendon, bone unit, So a lot of the times, people have lost capacity, you're trying to restore that. But, what's going to ultimately create a stimulus for bone is actually very different for tendon, So, bone, it's much more about the rate of loading, and with tendon, it's more heavy, slow resistance or isometric contractions, where you're trying to get up to higher intensity work. So you'll hear there's some really nice papers from Gerard McMahon. He wrote a paper called No Strain, No Gain. There's a nice systematic review from Lazaruk or Lazarchuk. I'm probably bastardizing the name, but those are great papers to read. So with tendon, what we know is that when you're dealing with a lower limb tendinopathy, generally we're going to see changes in Young's modulus, which is a slope of the stress strain curve. And you're going to see changes in the material properties of the tendon, namely being material mechanical properties, mainly being stiffness. So with running, you want a stiffer tendon because it's going to be it's better suited to withstand high strain, and it's also going to be able to store. It's going to be able to store and release energy more effectively. So if you're trying to restore these material properties, what we know is contraction type, not that important. So it's high contraction intensity in the form of isometrics or heavy slow resistance. So when you look at a lot of these papers, like there's an author, Aram Patsis, that, they've done some nice studies in the calf where they're showing that you almost need like 90% of a max voluntary contraction to elicit a 5% strain. And that's shown to be superior to even a 3% strain. So, now you can't always start there though. And like the message, Nathan and I were joking about this yesterday. It's like, oh, you have a tendon, just load the shit out of it and it's going to get better. Yeah. Well, how do you get there? Because if someone's coming off of a reactive Achilles tendinopathy, you can't just load the snot out of it. You have to sort of broach that. But we always say, don't leave the putt short because, with tendons, a lot of times the people who we consult are consulting us after maybe they failed or haven't really recovered to the extent that they were hoping for is runners. So in the common denominator there is people are far underloaded. So and we're still learning about certain benchmarks that we should be targeting. But the main thing is, you want to get people up to high contraction intensities, that are either in the form of isometrics for 3 to 5 seconds or, like 202 tempo training, 303 tempo training, where it's like 3 seconds on the eccentric or the descent, 3 seconds on the ascent. And that's what seems to provide the best mechanotransduction to get the tenocyte to react.
And I think as much as this helps this helps build some kind of physiological properties that we think are going to be helpful: bone density, tendon stiffness. It also helps to give that athlete confidence that they can stress the area that was painful, or maybe is still slightly painful with a tendon. But it also serves as a really good comparative sign for the individual. So I'll talk about this a lot. If you have a stress fracture in your femoral neck, often a side plank will hurt. Maybe a single leg squat will hurt, a split squat will hurt. Well, if we've gone through rehab and we've established that bone is tolerant to holding a side plank with your top hip abducted for 30 seconds, we now have that as a reference point. So when you're going through your return to run progression and you say, my hip feels off, it's not painful, but it feels stiff, it feels off, it feels something different. We can go back and say, well, we know that you can do this. How does this feel now? And if that's painful now, we can say, okay, well, let's take a step back. Or if you're like, this doesn't feel as strong, I can't hold as long. Sometimes that means, hey, we actually need to let's take a down week. Let's take a step back. Let's keep you running because you're not having pain. You're not having a relevant clinical exam, but it does seem a little bit off today. And then let's revisit this. I think along the way, that can be really, really helpful. Just like if you're dealing with a tendon, you're like, man, it really hurts to do that exercise now, and it didn't used to feel that way. We can help with that, can help us make some decisions as far as what to do in the short term and the long term.
As we wrap up here, what you all have mentioned some of them, but what are some big either misconceptions or mistakes commonly that you see either the sporting coach, the clinician, or the patient or athlete make throughout this process? Maybe Nathan, you can start from a BSI perspective, and on top of that, some big takeaways from this conversation. And then Chris, from a tendinopathy perspective, big mistakes and then big takeaways from this conversation.
Sure. Yeah, a couple things. And I've already kind of talked about some of this. The first one is that you should just focus on cross training or maintaining your fitness before you can run. So you've been diagnosed and you have a time period, maybe it's 4 weeks, 12 weeks, whatever it is, that almost becomes something where you just spin away on a bike, or you swim in the pool, or you aqua jog. I think we need to have a much more active approach during that process. And so that's, eventually a lifting routine that looks more like a solid strength routine. I think that needs to happen before. And so really understanding, like, we're trying to accomplish some stuff before you can run. It's not just going to be at the 8-week mark, you got cleared and now we can start a return to run progression, because I think that leaves runners underprepared. So that would be the first thing. If we go into nutrition, this is another thing that I'll often see. First, it's that understanding that nutrition is probably the biggest component with these. With bone stress injuries. And so get that assessed first. But if you meet with a dietitian and you talk about underfueling, wherever that's coming from, and then saying that, oh, I assessed that and I've got a plan and I'm good. That is much different than I'm having to make some kind of behavior change around my relationship with food. And that's going to be a continual thing. So, it's like, you can't just go in and get screened and then say, I'm good. That plan is going to need to be assessed and progressed, really moving forward. And again, this is when, it can be really challenging, because sometimes that's going to take extra resources monetarily. You're going to have to schedule appointments, all those kind of things. But I think that's really, really, really important. And then big jumps in training. I see this all the time with, again, especially with college kids, where someone gets back to training with their team and then you see this big spike. And almost always, I think it's the intensity that gets them, whether it's workouts and racing, and that makes them take a step back. And so understanding that this is going to be a longer process than you probably think it should be, making those decisions accordingly, I think is really, really helpful. Those would be the three big things that I'll see.
Chris, how about yourself?
Yeah, in terms of lower limb tendinopathy, I think that one of the sound bites that you'll hear me say in working with any athlete is, this is a game of addition by subtraction. Most of the time when people are dealing with these, what do? Well, they rest, then they stretch, or maybe they opt for needling, or whatever the case may be. So it's trying to get people concentrating on doing fewer things better, so which is good news to the patient, because I think a lot of runners walk around with their tail between their legs because they're not stretching. And when I'm like, hey, don't worry about it. I could care less if you stretch. If you want to, go ahead. But most of the time, runners are only stretching for, say, 10 to 30 seconds, which really isn't bringing about any kind of change. I think that people fail to load the tissue with the issue. And, I put that up as an Instagram post back in the day. And, what we know is that you need to load these tissues locally and then globally. So I think that people are finally warming up to the idea that, a lot of these Nautilus machines, which have been deemed, non-functional, are actually really darn important if you're dealing with a lower limb tendinopathy, because you're doing precisely what I mentioned. You're loading the tissue with the issue. So with the Achilles tendon, it's getting in a Smith machine, or doing some sort of focal calf raise. With the patellar tendon, it's a knee extension machine. With a hamstring, it's a prone hamstring curl early on. And I also think that, as Nathan mentioned, your training shouldn't look like a seismograph. If it does, you're screwed, right? Because that's what's going to get someone in trouble. With that said, I think it's really how you stagger these workouts that's really important, because, I was back in Pittsburgh visiting my parents recently, and I connected with this guy randomly in the parking lot who was going out for a run. And I said, hey, can I join you? And we were talking about his training. He runs 120 miles a week. You have to be squeaky clean with your workouts. You have to understand how bones, saturate, and then how much time it takes for them to regain their sensitivity to load. You need to understand how type 1 collagen turns over, and I think that's what we're really starting to zoom in on. Keith Barr's done some nice work on this stuff, but and I think that whether it's lower limb tendinopathy or bone stress injury, to really look at who this person is as an athlete, and then to look at their ecosystem and appreciate the presence of any allostatic load. So spitting out a program that's going to target a bone stress injury or tendon is actually not that difficult. It's communicating it to them and really like pulling this out of a vacuum and saying, this is a person going through life that faces certain stressors, and we need to understand those, which, sort of brings this conversation full circle. Nathan and I, maybe we have a little bit of a greater command with bone stress injuries or lower limb tendinopathy, but we're communication specialists. That's our secret sauce. But if you know the literature, you can present more compelling cases and help athletes understand the choices and the decisions that they have to make, that they ultimately have to make. So getting people to take ownership of their situation, that's critical.
And that's with both of these conditions being, again, we're thinking about long term. If I have a patient, they're not going to stay with me for 12 months. That's, Chris talked about his injury being 16 or 18 months. Like, you're not going to stay with a patient for that long. And so figuring out how to communicate and relay the relevant fundamentals with this, so then they can use it as they move forward. I think that's really, really important. Because we all have different things that are going on, and some of the stresses that you've got in life, whether it's work, financial, health, you got family members, you got other stuff going on, all that, a lot of that stuff is going to be unmodifiable. And so figuring out, how do I take these principles and apply them to what life looks like right now and maybe in the next few months, that's the biggest thing with both of these diagnoses.
All right. We'll call it there. Nathan, Chris, thank you both for coming on. This was great.
Yeah, thanks, Chris.
Thanks for having us.